Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. Today, our topic of discussion is about congenital cataract. Congenital cataract is one of the preventable causes of childhood blindness. But the most important thing is its timely detection, diagnosis, and proper management. To discuss this topic, we have invited and requested a scholar, Professor Paolo Nucci from Italy. Professor Paolo is a full professor in Università State di Milano, and he has got many teaching appointments in different foreign universities. He has been involved also in communication and health policies. He is a member of the Technical Commission of the Ministry of Health and Studies, and New Teaching Methods of Medical Teaching. He is an author of non-fiction, and he has credited 8 non-fiction books to his credit. And when we talk about scientific sector, he has got almost 250 research articles to his credit and 9 monographs. He is a member of several boards, journals, and societies. And currently, he is the president of Italian Society of Pediatric Ophthalmology and Strabismus. So we are very fortunate to have him today to deliver his talk on this very important and challenging topic. So without further delay, I will request him to please present his talk.
Thank you very much for your invitation, Alem. I know you since, LinkedIn connection, so we had an intensive discussion about formation. So it's really a pleasure to be here with your audience. The topic today is going to be congenital cataract, but mainly is related to the field of surgery in congenital cataract. And obviously, at this point, I don't want to be trivial because connected with you are a lot of specialists, of ophthalmologists, already with knowledges about congenital cataract. I want to go deep with not trivial points in the discussion of congenital cataract surgery. The first one is when you have to operate. And before answering the question of when we have to operate congenital cataract, we certainly have to consider the risk behind congenital cataract surgery that is mainly related to anesthesiological problem. As you may know, there was an increase in attention toward the problem of toxicity, neurotoxicity of anesthesia. But at this time, we can say quite surely that you are never young for anesthesia, and a single anesthesia is not going to be a problem, even for the developmental milestones of these children. So my point is that, as in this paper was already reported, an exposure to sevoflurane, that is the less toxic anesthesia that we are using, of less than 1 hour does not increase risk of adverse neurodevelopmental outcomes. It's important to stress that is always less than 1 hour surgery. Whenever you operate a congenital cataract, it's very difficult that lasts more than 20, 30 minutes, even in the complicated case. So we are dealing with a surgery that is less than 1 hour. The other point that possibly, if you have a toxicity, if for several exposures to anesthesia and not just one anesthesia. Of course, you are recalling me that when you deal with congenital cataract, plurimus, different, several anesthesia could be needed. But at this point, our society is stressing that it's not really so important to do several anesthesia because the toxicity comes from several exposure, frequent exposure to anesthesia. The other point that I want to mention and discuss with you is timing. And timing is crucial. We know that we have a time window for unilateral or bilateral surgery. When we deal with bilateral surgery, we have more time because it's less dangerous, this condition. Whenever you do a unilateral cataract, you have to be earlier. But still, there are several papers assessing the right period and the right window in which doing surgery. There are majority of the Americans are starting with very early surgery, 4 to 6 weeks, while the group of British surgeons, they usually wait a little bit more. I would say that is in between 6 weeks to 8-10 weeks correct surgery. I would never do a surgery before 6 weeks because even 2 weeks matters. So my point is that is an appropriate surgery in unilateral case to go in between the 6th and 8th weeks of surgery. The second point is that whenever this is an article, this is a review article published in Eye in 2020 that you, as I mentioned, the window is between 3 to 7-8 weeks of age. In the period in which you are not considering surgery, you can do what is considered the best way to wait to prepare the child for surgery. And this is a so-called part-time patching that is considered protective toward amblyopia. You always have to remember that the child has interrupted waking hours. So if you prolong the patching hours, is almost dangerous. So in the period between 0 to 3 weeks, considering that waking hours are 3 to 4 per day, a less than 1 hour patching regimen is suggested. When you go over 3 to 6 weeks, the waking hours increase to 4 to 8 hours. So you can reach also 2 hours of patching in order to protect from amblyopia. This is the real window. In between 8 to 12 weeks, there is the window for the unilateral, and 10, 12 to 14 weeks for unilateral. Don't go more and over this period for doing surgery. Of course, if you have a very dense opacity and the dimension is 3.5 millimeters, you can do a little bit earlier. If you have less than 3.5 millimeters and mild opacity, you can wait a little bit. So this is just to remember that you have a kind of direction in what you have to do for time. So let's move to surgery, because I'm sure, Alem, that people is involved mainly for doing surgery, and they want to have information, practical information in dealing with this complicated surgery. The first important thing is the dilation protocol. And since we have the availability of tropicamide, phenylephrine, lidocaine for intracameral surgery, for cataract surgery, the intracameral injection is by far the most relevant, most important news in this field. You can see that you have no adverse event. There is no need for a second injection. So just one injection is enough, and is also a dilation that is easily reversible with acetylcholine. And this works not only in normal congenital cataract eye, but also in PFV eye. You see that a single simple injection in a complicated eye, you will see here the stretching of the ciliary body, assessing that this is a real PFV. And also in PFV, a single injection of this preparation allows you to have a significant dilation for surgery. So this is the main point that changed my surgical life in the last years. Let's move to other question that is an important question. where you are used to do superior or temporal or two-port incision. My point is that superior part of the conjunctiva and the cornea should be protected from surgery because it's a possible site for surgery for a glaucoma surgery. So if you are waiting for the possibility of a complication like glaucoma, my opinion is that you have to preserve the superior part. It is the most covered part and is important for a bleb formation or any other type of surgery. So since I'm also an adult cataract surgeon, I feel very comfortable with a temporal incision. So you spare the superior limbus and is also a more comfortable access. This is a one-port incision, just in an older child. This is the best approach, in my opinion. Obviously, creating another port in order to manipulate the nucleus. The other question is better a one-port or two-port incision? At this time, I moved to a two-port incision in all the cases. This because both incision goes under the lids, so are protected, and at the same time you have the possibility to actually do a fast and easier irrigation aspiration at the equator. Sometimes with a single incision, single port, you have the difficulty to manipulate the nucleus and to aspirate. So by manual technique is better also for managing the calcific nuclei that are often seen. And this is what I usually do. In this case, specific case, we have another incision for the possibility to work for the capsular axis, posterior capsular axis from behind. So this is the reason for the trocar in that picture. Another important tip, Alem, that I want to share with you is that capsular axis is quite different in children with respect to adults. In all these cases, you have to use a cohesive high molecular weight viscoelastic, and my attitude is always to use the blue to color the capsule. The movement that you have to do is always a centripetal movement, and you have to aim to a small diameter of incision. I will tell you why. You see, I do use this type of forceps. That is a forceps, coaxial forceps. Is very simple. You see the movement is centripetal, and I aim to a smaller diameter, less than 4.5 millimeters. I want to tell you and demonstrate to you, if you are doing a smaller rhexis, the possibility of the rhexis that goes out is very low because you are not touching in any way the equatorial part of the zonule that creates the traction for the rupture of the capsule. And at the same time, if you aim to a smaller diameter, I want to show you that with time, when you put inside the lens, I do use always a three-piece lenses because it's an increased tension of the capsular ring. You see that the diameter of the same opening is increasing by almost 1 millimeter. So from 4 to 5 arrives to 0.23. This because is a three-piece lenses, but also when you use not the three-piece, you will see that there is an enlargement. There is a natural tendency to enlargement of the capsular axis, and 5 millimeters is a reasonable dimension for the rhexis. Another point that is a controversial point is the point of the hydrodissection. There is actually no need to rotate the nucleus. At the same time, the material is very soft, and you don't know the integrity of the posterior capsule. So the time you spend is almost equal to the time you spare. My attitude toward hydrodissection is to avoid it, because the main concept for my surgery is that less is more. So rarely I do hydrodissection in children. Another point that you have to keep in mind is that the real part that creates the sommering ring is the posterior part of the anterior capsule. So you have to spend time in order to take out these cells. You see that there is a point in my surgery in which I do the cleaning of the superior part, rotating the tip towards the capsule. And this allows you to decrease the number of cells of the superior capsule that are the ones that grows vertically, creating the sommering ring. So this is another, I would say, tip for our colleague when they deal with the congenital cataract. Again, obviously, when you deal with children less than 6 years, posterior capsulectomy followed by a posterior vitrectomy is really relevant. There is someone that does a posterior capsulorhexis. I think is a simpering, because whenever you go inside the capsule, posterior capsule, the capsule is very fragile, so there is no need and no reason to go and create a rhexis like the anterior part. You just go inside with a capsule, with a vitrector, and you do a perfect opening. I'm still using from the anterior capsulectomy the 23 gauge needle, but now sometimes I use a 25 gauge. I do prefer 25 gauge when I go posteriorly and when I do a posterior capsulectomy through an opening in the pars plana. Otherwise, 23 is okay, even because you have to eat vitreous. The vitreous in a child has what we call an up thrust, so comes, in the anterior part. So if you have a larger mouth of the vitrector, is good. Usually it should be a little bit less. Even the posterior capsule will enlarge with time. The vitrectomy should be generous. Don't be afraid, because the vitreous of a child is very hydrophilic. So you stop the operation and the eye is very soft and you are worried. If you go and see the pressure the day after, the pressure is almost, completely resolved. There is no hypotonus, because the vitreous of a child is very hydrophilic. The other important thing is that you have to undermine the posterior capsule, because sometimes you have to create just an empty ball, because otherwise the cells grows over the central part of the vitreous. I do anterior vitrectomy if I do not implant. If I do a posterior, if I implant a chamber, usually I do the posterior capsulectomy after inserting the IOL, and then I do posteriorly to create it. Because the vitreous of a child could comes up and rotate the lens at the end of the procedure, and you can have a capture of the IOL disc. I do prefer doing this. I always check if there is vitreous in anterior chamber. I do use, just touching the scar, the incision, to see if there is even a small strand. The strand is always dangerous for the safety of the retina. Whenever I do pars plana, according to the age, I do pars plana vitrectomy 2.5 to 3 millimeter when I do an implant. I want to show you the anterior approach. This is when I put the IOL. This was not a three-piece. You see in the right image, you have both. You see with the posterior approach, it's very easy to do the vitrectomy. In the anterior approach, you have to move a little bit the lens, and then At that time, I was still using the 20 retractor. This is an image of many years ago. You see, this is a very big retractor, and the retractor should be generous, otherwise, you know, the lens comes out. In doing a posterior approach, you see that you have to close one of the incision. You use the other port to increase the amount of the irrigation, and then you go with the retractor, you see. You see how easy is the posterior approach. It's very easy, simple. It is not traumatic. There is no possibility that the matrix comes out. Whenever you take out the retractors, obviously you have to continue to eat. This is a very fast registration, so but actually the movement are quite less relevant. And the important part in a child that you don't have to put any sutures, because the sclera is very elastic and comes on the so I do not put any sutures. And you see the result is quite good for both approach, but now my preferred approach is the posterior one. And now let's go to the last part of this talk, and is about IOL, a primary implant. That is really the problem and the question. And we have several points that are open when we deal with the primary implant. In a child over age 2, my point is that you have to implant. But whenever you implant, you have to consider to make this child very hyperopic, because the myopic shift is the rule. And the reason for which myopic shift is the rule in congenital cataract is because you have to understand that smaller eyes are the base, the fundamentals of the growth of the eye. Hyperopia is functional to emmetropia. When you operate a child of cataract, you are creating a big hyperop. And being hyperop means that the focus could fall very behind. So the eye grows in order to reach that focus. This is the reason that I believe, strongly believe, is at the base of myopic shift in congenital cataract surgery. So whenever you operate this child, you have to maintain the child with a lens that is a little bit less corrected. So you have to aim to an hyperopia. At the age of 2, my point is that I want to leave them 5 to 6 diopters hyperopic. I'm sure that this child will become myopic with time, but I deal preferably with a -2, -3 of myopia instead of an emmetropic eye with the risk to remain hyperopic. So my choice is to put an IOL at the age of 2 of about that creates about 5 to 6 diopters of hyperopia. The other important point is that whenever you put an IOL in a child, you have to remember that one of the causes of amblyopia is the lack of accommodation. So you will never have success visually in a child that does not accommodate. So you can strive all your life to have perfect vision in a monocular cataract, but you will never reach that point. You could have a good visual acuity, I would say 20/50, and is a good results, 20/40, but you never have to aim to a 20/20 because it is a not accommodating child. And that kind of amblyopia will never be the same of the other eye. And the real enemy in amblyopia is the good eye. It's not the condition. It's not the lack of accommodation. It's not the defect that you have. It's the good eye that is very selfish and maintains all the attention for the good eye. The type of IOL and the calculation formulas, you have an idea of many calculation formulas. This is an interesting article about intraocular lens power calculation. My point, and this is obviously the infant aphakia treatment study, the 2022 excellent study by Scott McClatchy, is the one who studied a lot this condition. And you see that in conclusion, results from this longitudinal study of biometric measurement suggest that the axial length keratometry alone cannot fully explain prediction error in pediatric patients. And this gives the right to me to say that myopic condition in this situation is not just related to an equilibrium in between keratometry and axial length. It can be something more. So another important thing is that anterior chamfer depth is very important. Now there are a lot of calculations that consider also this anterior chamfer depth. And this is the real variable that we cannot assess. You see, these are the management of the IOL, the initial refractive goal for if IOL is implanted. You see that from 0 to 1 is +9 to +6 is too much. Barrett formula, universal 2 formula is one of the most important. At this time, I'm using this Ofter QST. ST is Savini-Taroni, that changed the Ofter Q. I want that you record this and you take a picture of this excellent formula that I'm now using since a couple of years for cataract, for IOL implantation in children. The last point is that I'm quite against multifocal IOLs in children, quite against as all the literature in the world, because multifocal IOL are usually good for very precise surgery in which the centration is perfect and the reading distance is 33 centimeters. We are dealing with an hyperopic target, unpredictable axial growth, reading distance of very close, because the children, they see at this distance 12, 15 centimeters. And you have always to remember that one of the main important cause of IOL removal in older patients is multifocal implant. So if they are not safe in older people, they are not safe, obviously, in children. And with this, Alem, I think that I completed my experience to share with you. So I'm ready for a discussion with you.
Well, thank you, Prof. You have explained it in great detail on all these aspects about the management of congenital cataract. One thing is, Prof, regarding primary IOL, what do you think about making it aphakia and using the contact lenses? What is your opinion about this, Prof?
My opinion is always in favor of contact lenses. Unfortunately, as you may know, the best contact lens that was used in children until 2 years ago that were produced, but not anymore in production. So we are orphan of the good contact lens for a child. But certainly, contact lenses are the best option. And when you deal with a cataract before age 2, age 3, the best option is congenital cataract until the eye grows. And then you can put a secondary implant. If you did a correct surgery, secondary implant is not an issue. It's quite easy and is a safe procedure.
Well, Prof, if there is bilateral congenital cataract, how do you plan that as compared to the unilateral cataract?
Sometimes in the last years, since our surgery is very easy and is easier than in the past, I do prefer to do both in the same period. But you have to consider that doing the surgery in the same setting means that you have to change, everything of the operating tables. So you have to use a second retractor, a second EI. So it's like a second procedure, but you have to maintain the time below 1 hour of operation. Usually my attitude that I can do this surgery, both surgery, even with changing everything in about 40 minutes. So this is my option. Even if bilateral cataract is a forgiving procedure, because in bilateral cataract, I have patients in my life, I would say is the 70% of my experience, that have 20/20 vision. This never happens with unilateral cataract.
Prof, what about infant aphakia treatment study mentioned glaucoma and these congenital cataract surgeries? How do you anticipate and manage these things regarding new IOL technologies?
I think that this is my opinion, obviously, Alem. I'm sharing with you a personal opinion, so there is nothing proved of what I'm saying. But my opinion is that congenital cataract drives the glaucoma, because whenever you operate a smaller eye that is still growing, if you take out an important part of this 7 grams organ, you change the morphodynamic of the eye. So if you take out the lens, you take out some weight inside that allows the ciliary body to tend to go centripetally. So my opinion is that without lens, the trabecular meshwork stays compact instead of creating the network that usually is created. So my idea is that an anatomical problem in which trabecular meshwork doesn't develop in the right way. This is my opinion. I don't think that inflammation, I don't think that there are problems in the angle. I think it's just a morphodynamical process.
Prof, regarding these dropless surgeries, now in adults we are putting triamcinolone and moxifloxacin injections. Anything coming in pediatric cataract surgery also, these things, or not yet?
Yes, we do an injection of antibiotics. I do not really trust that antibiotics are really useful. But I will tell you, I will confess you, is something that we consider as a protection legally. Because if you do an injection, no one can tell you, why didn't you do an injection in this patient? So certainly I will use my drain when I do a dilation at the very beginning. At the end of the procedure, I use an antibiotic injected inside, not because I'm convinced that it works, but just to protect myself, because someone could say, why didn't do this? It's a so simple procedure, you had to do this. So I know that is not really something ethically correct, but is my point.
Well, Prof. Paolo Nucci, it was a pleasure and it was worth attending your lecture. And I want to thank you on the behalf of my channel, my WhatsApp group, my audience, that in spite of your very busy schedule, I know you are busy with your research, your patient management, and above all, you have administrative duties, so many things going on, but you gave us time and educated my audience. So I want to thank you on the behalf of our audience. And we are looking forward to more lectures in future also.
Thank you. I appreciate it. Thank you. Bye-bye.
Thank you, Prof. Thank you.